Hello everybody and welcome to our module on intrinsic hemolysis. So recall that a normocytic anemia is an anemia where the MCV is within the normal range between 80 and 100, and in the module on hemolysis basics I talked about how normocytic anemias could be divided up into two groups. One group are those anemias from underproduction by the bone marrow. The other group are those normocytic anemias that come from increased destruction of red cells, and these are called the hemolytic anemias. And the hemolytic anemias can be divided into two groups. There are those that are caused by something extrinsic to the red cell, and we have our own module on these. In this module, I'm going to talk about hemolytic anemias that are caused by something intrinsic to the red cell, in other words, some normal part of the red cell that becomes aberrant and starts to cause hemolysis. So we'll talk about a number of these disorders. I'll talk about all of them except for sickle cell and hemoglobin C, which have their own module. So the first disorder we'll discuss is paroxysmal nocturnal hemoglobinuria, or PNH. This is a disorder where hemolysis occurs because red blood cells are destroyed by the complement system. Normally the complement system does not lyse red cells, it only lyses bacterial cells and other pathogens. The reason red cells normally don't get lysed is because they have protective proteins on the red blood cell membrane. And in PNH there is loss of those protective proteins, and this leads to complement destruction of red cells. So those protective proteins go by names like decay accelerating factor, or DAF. This is also sometimes called CD55. Another important one is the MAC inhibitory protein, which is also called CD59. When red cells lose these protective proteins, the complement system will lyse red blood cells, and this predominantly occurs inside of blood vessels. Therefore, it results in intravascular hemolysis. There is sometimes a little bit of extravascular hemolysis. That's because when red cells are coated with C3 fragments by the complement system, the macrophages can recognize these and destroy the red cells inside the spleen. PNH is an acquired condition. It results because at some point in a person's life, for reasons we don't completely understand, they develop a genetic mutation in their hematopoietic stem cells. These mutations lead to loss of something known as a GPI anchor molecule. GPI stands for glycosyl phosphatidylinositol. And these are large lipid and glucose molecules linked together that serve as anchors in the red cell membrane. And what they do is they attach proteins to the surface. So when you lose these GPI anchors, you cannot attach proteins to the surface. And as a result, the red cells lose DAF and CD59 like we talked about on the last slide. This leads to lysis by the complement system. Now, because the problem is in a hematopoietic stem cell, it's not just the red cells that have issues, it's also the platelets and white blood cells. They can also be lysed by the complement system. So in addition to the symptoms of anemia that occur, you can also get problems with low platelets and low white counts. PNH gets its name because it classically causes sudden episodes of hemolysis at night. A paroxysm is a sudden episode, nocturnal means at night, and the disorder results in hemoglobin in the urine, which changes the color of the urine. So people with this disorder classically have episodes at night where their urine changes color. The reason the hemolysis classically occurs at night is because there's a mild slowing of your respiratory rate when you sleep. There's also slightly shallower breathing during sleep. This leads to a little bit of a rise in the CO2 level and a mild respiratory acidosis. And mild respiratory acidosis can trigger complement activation. So there's an increase in complement activity at night, and that often triggers these episodes of hemolysis at night that define the disorder. The symptoms of the disorder include fatigue and dyspnea, and this results from anemia. When you hemolyze at night, over time you will become anemic. In addition, these patients often lose iron in the urine, and it's very high yield to remember this. Iron deficiency is a very common finding among these patients, and the need to replete their iron is an important part of treating the condition. If anemia were the only problem in PNH, it might not be so bad, but what makes this a serious disorder are two other features. One is abdominal pain. These patients classically get episodes of abdominal pain from smooth muscle tension. We'll talk about why in a minute. And then the second big problem in this disorder is thrombosis. This is the leading cause of death. These patients are hypercoagulable, and they often develop venous clots, and they tend to get them in unusual locations like the portal vein or the mesenteric veins or the cerebral veins. In addition, because this disorder involves abnormalities of the hematopoietic stem cells, some patients develop acute myeloid leukemia, or AML. Sometimes the stem cell mutation progresses and they develop acute leukemia. The lifetime risk is about 5% or less in patients who have PNH. On this slide, I've bolded the clinical features of PNH, so let's walk through this concept map so you can understand why they all occur. As I told you before, the primary problem is hemolysis because red cells are being lysed by the complement system. This can lead to anemia over time. In addition, hemoglobin can spill into the urine. This can cause the urine to become dark and change colors. Patients often notice that, and in addition, it can potentially lead to renal failure. The free plasma hemoglobin that is released after hemolysis is a big part of the problem in this disorder. Free plasma hemoglobin is thrombogenic, so this can lead to thrombosis. In addition, as I told you before, platelets are also lysed in this disorder by the complement system, and so they can spill their granule contents, and many of those contents promote thrombus formation, so that can also lead to thrombosis. Another problem with the free plasma hemoglobin is that it binds nitric oxide. You may know that nitric oxide is a smooth muscle relaxant. When free plasma hemoglobin binds nitric oxide, this can deplete nitric oxide. This can lead to an increase in smooth muscle tone, which is a big part of the problem in this disorder. That can lead to problems swallowing, which many of these patients have. It can lead to abdominal pain, which many of these patients complain of, and it can potentially lead to erectile dysfunction, which is also very common. Many of the symptoms in this disorder, especially the belly pain and the dysphagia, are relatively nonspecific, so these patients are often undiagnosed for some time until an astute clinician puts it all together. So this disorder should be suspected in anyone who has evidence of a hemolytic anemia and also an unexplained thrombosis, especially a thrombus in one of those unusual venous structures like we described. Lab testing may show typical evidence of hemolysis like you can see in many disorders, so you may see a high LDH level, a low haptoglobin level. There may be evidence of hemoglobin or hemosiderin in the urine. If the direct antibody test or the Coombs test is performed, it will be negative. That is a test for antibodies coating the red cells, and antibodies are not part of the problem in PNH. The way you confirm the diagnosis is by doing a test called flow cytometry. In flow cytometry, you take monoclonal antibodies that attach to GPI-anchored proteins, and then you can detect whether or not those antibodies have attached. What you will find is that the antibodies are not attaching because the cells are deficient in the GPI-anchored proteins. Treatment of PNH is complex, but you should be aware that there is one therapy called eculizumab, which is an anti-complement therapy. Eculizumab is an antibody that binds to complement component C5, and it prevents C5 from splitting into C5a and C5b. And if you've watched the module in the immunology section on the complement system, you know that C5b is important for forming the membrane attack complex, which lyses cells. So this antibody will protect against intravascular hemolysis by the complement system. It does not, however, protect against extravascular hemolysis. C3 fragments can still form and bind to the red blood cell surface. They can go to the spleen where the red cells can be phagocytosed. So treated patients still may have a mild anemia, but importantly, in the clinical trials, it's resulted in stable hemoglobin levels and fewer transfusions for patients with PNH. Our next intrinsic cause of hemolysis is deficiency of the enzyme pyruvate kinase, and this disorder ties in heavily with biochemistry. That's because pyruvate kinase is a key enzyme in glycolysis. Its role is to convert phosphoenolpyruvate into pyruvate, and when levels of this enzyme are low, red blood cells tend to be the most affected cells. That's because they lack mitochondria, and they require pyruvate kinase and glycolysis for anaerobic metabolism. And when they cannot effectively perform anaerobic metabolism, what happens is that the membrane fails. Red cells need ATP to maintain the structure of their membrane. Recall that they have a very flexible, pliable membrane. If they don't have enough energy, the membrane becomes rigid, and this leads to phagocytosis of the cells in the spleen. And a principle of hemolysis you should always remember is that when there's a problem with membranes, those red cells tend to get phagocytosed in the spleen. This is an autosomal recessive disorder. It usually presents in the newborn period with signs and symptoms of extravascular hemolysis. The hemolysis occurs in the spleen, and thus it is extravascular. The baby will have an enlarged spleen on physical exam, and the disease severity depends on how low their enzyme levels are. So if they have a mild decrease, they may have a mild extravascular hemolytic anemia. If they have a severe decrease in pyruvate kinase, the symptoms can be very serious and life-threatening. Our next intrinsic cause of hemolysis is a deficiency of the enzyme glucose-6-phosphate dehydrogenase, or G6PD. And this disorder also ties in heavily with biochemistry, and that's because G6PD is a key enzyme in the HMP shunt. And I have an entire module on the HMP shunt that you can watch in the biochemistry section. Recall that the HMP shunt is necessary for generation of NADPH, and NADPH is important for protecting red cells from oxidative damage. In particular, hydrogen peroxide is toxic to red cells. It can lead to oxidative damage, and hydrogen peroxide inside of red cells is generated in response to certain well-described triggers, which are a big problem in patients who have a G6PD deficiency. Those triggers include things like certain infections, certain drugs, and especially fava beans. All of these lead to lots of hydrogen peroxide generation, and the red cells need NADPH to break down the hydrogen peroxide, but if they don't have enough NADPH because they lack this enzyme, this leads to hemolysis. This is an X-linked recessive disorder, so it's more common in males. It's the most common human enzyme disorder, although overall it's still relatively rare and you won't see it that frequently. It results in recurrent hemolysis after exposure to one of the classic triggers. When patients are exposed to one of those triggers that increases the hydrogen peroxide production inside of red cells, the red cells become rigid and they cannot maintain the flexibility of their membrane. And as I told you before, when cells become rigid and can't maintain their membrane, those red cells are consumed by splenic macrophages. So there is a lot of extravascular hemolysis that occurs in a G6PD deficiency. In addition, there is some lysis in the red cells. Some of the cells become so oxidatively damaged and so rigid that they lyse inside the vasculature, so you can also see intravascular hemolysis. I mentioned the common triggers of hemolysis in patients with a G6PD deficiency before, but let's talk about those in a little bit more detail. So when patients with this disorder have an infection, macrophages inside their body can generate free radicals. This can lead to hydrogen peroxide production inside of red cells, and this can lead to hemolysis. So these patients classically develop hemolysis in the setting of various different types of infection. Another classic trigger is fava beans. In some of the places in the world where G6PD deficiency is common, patients consume lots of fava beans, and they contain oxidants which can lead to hydrogen peroxide generation. This can lead to hemolysis in these patients. And then finally, there is a long list of drugs that these patients need to avoid. Some of these include antibiotics. Sulfa drugs are a classic trigger. So is dapsone, which is a rarely used antibiotic, as well as nitrofurantoin and isoniazid. Antimalarials are well-described triggers of hemolysis in this condition, and G6PD deficiency is common in parts of the world where there is malaria infection. So for example, primaquine and quinidine can trigger hemolysis in patients who have this condition. And then finally, aspirin and acetaminophen have rarely been described as triggers in this condition as well. And when patients are diagnosed with a G6PD deficiency, they usually become educated very quickly on what drugs they need to avoid. You will read in your textbooks that G6PD deficiency has a high prevalence in Africa, Asia, and the Mediterranean, but let's talk a little bit about exactly what that means. On the screen here is a map showing prevalence of G6PD deficiency, and you can see that the most common place is in Africa. The most common location is sub-Saharan Africa. The Sahara Desert is in northern Africa, and it's these countries below the Sahara where most G6PD deficiency is found. There's also some of it in countries of the Middle East, and because they are near the Mediterranean Sea, you will sometimes see it said that people of Mediterranean descent have high G6PD, but really it's mostly a problem in Africa. And the reason that it's most common in Africa is probably because it may protect against malaria. There's some evidence that G6PD deficiency is protective and limits the ability of Plasmodium to infect red cells, and therefore a high prevalence evolved in places where there's lots of malaria. So the classic presentation is a patient from Africa who develops the sudden onset of jaundice, dark urine, and anemia. They may also have back pain that can be caused by the free hemoglobin, and the onset of the episode is after exposure to one of the typical triggers. There are two classic findings you should know on peripheral blood smear of patients with a G6PD deficiency. One is called a Heinz body, the other is called a bite cell. Heinz bodies are red cells with small dark areas inside of them. The dark areas represent oxidized hemoglobin that has precipitated inside of the red cell. This is seen with a special stain called a Heinz body stain. It's sometimes called a Heinz body preparation. It looks something like what I've drawn on the screen here. They are red cells with these dark inclusions. Bite cells are cells that literally look like they have a bite taken out of them, and this is because of phagocytic removal of a portion of the red cell by splenic macrophages. They often cannot engulf the red cell whole, so they take a piece of it out, and this results in the formation of bite cells, which you can see on the peripheral smear. If you suspect this condition, the screening test is called a fluorescent spot test. It detects the generation of NADPH from NADP. Patients with this deficiency are unable to generate normal levels of NADPH, and that's what this screening test looks for. To do this test, you add glucose 6-phosphate and NADP to the patient's red cells. You then see if the cells fluoresce under UV light. If the patient has normal G6PD levels, they will generate lots of NADPH and the cells will light up under UV light. However, if they're deficient in the enzyme, they will fail to fluoresce normally under UV light. That's a positive test, meaning that the patient likely has the condition. Importantly, you need to test outside of an acute attack. Right after a patient's been exposed to a trigger, they have destruction of the cells that have the lowest enzyme levels. The ones that are left behind may be the cells that have higher than normal enzyme levels, so they may test normal. You've got to wait until the patient reaches a steady state, and then you can perform the test. And the treatment is mostly to avoid the triggers. Our final intrinsic cause of hemolysis that we'll discuss in this module is called hereditary spherocytosis. This is a hereditary disorder. As the name implies, it tends to run in families. It can be autosomal dominant or recessive, and it results in the formation of spherocytes. This is a picture of a spherocyte in the middle of this blood smear on the screen. Note that it is slightly smaller than normal red cells. It's got a spherical shape, and it also lacks the central pallor that you see in normal red blood cells. In the module on extrinsic causes of hemolytic anemia, I told you that spherocytes could form in certain types of autoimmune hemolytic anemia. In those disorders, the spherocytes were formed because of antibody deposition on the red blood cell membrane. Spherocytes also form in hereditary spherocytosis, but the mechanism of their formation is completely different. In hereditary spherocytosis, spherocytes form because of cytoskeleton abnormalities. There are many proteins that tie the cytoskeleton of the red cell to the red blood cell membrane. These are very important in the red cell. They are what give the red cell its biconcave shape and allow the cell to be flexible and pliable so it can move through the circulation. If one of these proteins is abnormal, that can lead to a rigid membrane, which leads to the hemolysis in spherocytosis and the formation of spherocytes. There are lots of different proteins that are involved in tying the cytoskeleton to the red blood cell membrane. I've shown a picture of some of them on the screen here. Many different proteins have been described as being abnormal in different cases of hereditary spherocytosis. Some of the commonly involved proteins include one known as spectrin. Spectrin is this double strand running the length of the membrane here in this picture. It's often involved in hereditary spherocytosis, and it's easy to remember because it begins with the letters SP, just like spherocytosis. Other proteins that have been described as being involved in hereditary spherocytosis include ankyrin, shown here, also band 3, shown here, also band 4.2, and also a number of other proteins that are not shown in this picture. It turns out that the spherocytes work just fine at carrying oxygen. The oxygen carrying function is normal. The problem in spherocytosis is chronic hemolysis by destruction of red cells in the spleen. These patients have chronic extravascular hemolysis because those red cells with abnormal membranes go through the spleen and they are phagocytosed. So these patients classically develop splenomegaly. There's growth of the splenic macrophages. They will have all the classic findings of hemolysis, increased bilirubin, jaundice, and bilirubin gallstones as well. As the red cells of these patients circulate through the vasculature, there is progressive loss of the cell membrane. In other words, over time, more and more of the membrane is lost. This results in a high RDW. So let's talk about what the RDW is. RDW is the red cell distribution width, and normally it is pretty narrow, as shown in this picture here. In other words, you have some small red cells, some large cells, but their sizes don't distribute that much. They're relatively close in size from the smallest to the largest. On the other hand, patients with spherocytosis can have a much wider RDW. This is because those spherocytes are losing their membrane progressively over time. That results in a large spectrum of cell sizes, and if you measure the RDW for a patient who has spherocytosis, you will find that it is increased because of the progressive membrane loss. Even though there's progressive membrane loss over time, the volume of material inside the cell does not change. This means that the material inside the cell gets packed closer and closer together as membrane is lost. This leads to a high MCHC. The MCHC is the mean corpuscular hemoglobin concentration. In a normal cell, all the hemoglobin is spread out over a large cell. In a spherocyte, it's the same volume but a smaller cell, so everything is packed closer together, and you see a rise in the MCHC. This is a classic finding when you analyze red cells in patients with spherocytosis. The MCV, which is the mean corpuscular volume, which is the average size of red cells, is usually normal or low. That's because the spherocytes are small, so they have a low MCV. However, these patients have chronic hemolysis, so they have more reticulocytes than normal in their peripheral blood. The reticulocytes are larger than usual. They have a high MCV, so when taken together, the overall average size of the red cells is usually normal or slightly low. It's very unusual for the MCHC and the MCV to go in different directions. Usually they go together. This is one of the unusual scenarios where you see a rise in the MCHC, but you can see a drop in the MCV. There's an important tie-in with cardiovascular physiology in patients who have hereditary spherocytosis. The loss of membrane flexibility leads to more rigid cells. This leads to a higher resistance to blood flow in the small vessels. In the cardiac physiology modules, I talk about how resistance is proportional to a number of different factors via Poiseuille's law. One of those factors is the viscosity of the blood. The viscosity of the blood will go up when you have rigid blood cells present, as occurs in hereditary spherocytosis. Just like any patient with chronic hemolysis, these patients are at risk of aplastic crisis if they become infected with parvovirus B19. This virus infects red blood cell progenitor cells, and it decreases the production of red cells. And patients with spherocytosis are dependent on their bone marrow to replace the hemolyzed cells. So if they become infected with this virus, they can develop a severe drop in their red blood cell count. That's called an aplastic crisis, and they can become very sick. This is often the initial presentation of a child. They may get an infection with B19, and that's when their anemia becomes detected. So the hemolysis from spherocytosis may be compensated until the child is exposed to B19. At that point, a workup is done and spherocytosis is seen on blood smear. And importantly, especially for board questions, make sure you don't confuse this with G6PD. You should not see spherocytes in G6PD, but because this patient has an infection and then develops anemia, that can often appear to be a description of a patient with G6PD who has infection as a trigger of hemolysis. It's the spherocytes that will tip you off that it's a case of spherocytosis. You can make the diagnosis of hereditary spherocytosis by performing a test called the osmotic fragility test. This test is based upon the principle that spherocytes are more susceptible to osmotic lysis compared to normal red blood cells. Because they have abnormal membranes, they have a poor ability to swell in hypotonic solution compared with normal red blood cells, and for this reason they will lyse more easily in hypotonic solution. To perform this test, you measure the hemoglobin that is released when a sample of blood cells is placed in a hypotonic solution. From this, you determine the osmotic fragility, and the osmotic fragility will be increased if spherocytosis is present. The treatment for this condition is to perform a splenectomy and remove the spleen. Remember what I told you earlier, spherocytes are normal in terms of their oxygen carrying capacity. The problem in this disorder is the chronic hemolysis. If the spleen is removed, then the hemolysis will resolve. Spherocytes will still be present, but that's okay because they can carry oxygen just like normal red cells. Now, one important thing you should know about patients who have had their spleen removed for spherocytosis. When this is done, Howell-Jolly bodies will appear in the peripheral blood. This is a picture of a Howell-Jolly body shown on the screen here. It's a small inclusion inside of a red cell. The reason Howell-Jolly bodies appear when the spleen has been removed is because some red cells normally leave the marrow with nuclear remnants. These red cells are usually cleared by the spleen. But if a person has splenic dysfunction for any reason, including if the spleen has been removed, then the Howell-Jolly bodies will appear and be present inside of red cells in the peripheral blood. The reason I'm telling you this is because a classic finding that often appears in board exams is a peripheral smear with both spherocytes and Howell-Jolly bodies present. That peripheral blood smear is from a patient who has spherocytosis and has had their spleen removed for treatment, and therefore what you now see in their peripheral blood is both spherocytes and Howell-Jolly bodies. And that concludes our video on intrinsic hemolysis.